Hello everyone, welcome back. Today I'm going to simplify the 2026 Dyslipidemia Guidelines in a way that will actually change how you treat patients tomorrow. Because the biggest mistake we make is not wrong knowledge, but incomplete application. So let's start with LDL measurement. Don't rely on Friedewald anymore, especially when triglycerides are high. Because it underestimates LDL, and studies by Sampson and others clearly show that newer equations like Martin Hopkins are more accurate, which means in a diabetic patient with high triglycerides, you might otherwise miss the need to intensify therapy. Now moving to ApoB, remember this reflects the number of atherogenic particles and not just cholesterol content. And evidence from Snyderman shows it predicts risk better in many patients. So when LDL looks normal but triglycerides are high, ApoB can uncover hidden risk. Next is LPA, and this is crucial. Measure it once in every adult because it's genetically determined and strongly linked to premature heart disease as shown by Tsimikas. So when you see a young MI patient with normal lipids, think LPA. Now for risk assessment, the new Prevent calculator gives a more accurate risk estimate, and once you categorize patients into low, borderline, intermediate, or high risk, your treatment becomes much clearer. But don't stop there. Risk enhancers like high hsCRP, proven in the Jupiter trial, or a history of preeclampsia or early menopause can push you towards starting statins even when risk seems borderline. Then comes CAC scoring, which is a game changer in uncertain cases. If CAC is 0, you can safely defer statins in low-risk individuals. But once it's above 100, treatment is strongly indicated. And above 300, you must be aggressive, as shown in the MESA study, making this extremely useful in patients who hesitate to start lifelong medication. In primary prevention, low-risk patients need only lifestyle changes. Borderline risk may need statins if enhancers are present. Intermediate risk clearly benefits from moderate statins. And high-risk patients require high-intensity statins with targets below 70, supported by large meta-analyses and trials like Improve It showing that lower LDL truly translates into fewer events. When LDL is above 190, don't even calculate risk. Start high-intensity statins immediately and escalate with ezetimibe or PCSK9 inhibitors if needed, as proven in FOURIER and ODIDA-CSY trials. And in familial cases, newer agents like evinacumab can be life-saving. In diabetes, every patient between 40 and 75 should be on at least moderate statins because diabetes itself is a high-risk condition. And if additional risk factors are present, go aggressive. In secondary prevention, this is where you must be strict to use high-intensity statins. Aim for LDL below 70 or even 55 inches, very high-risk patients, and add ezetimibe or PCSK9 inhibitors stepwise, with strong evidence from Prove It, Improve It, and FOURIER. And for patients who struggle with adherence, inclisiran offers a convenient option. Don't forget, triglycerides levels above 500 increase pancreatitis risk, so treat urgently with fibrates or omega 3s. And above 1000 requires immediate A, while emerging therapies like APhA 3 inhibitors are showing promise. In special populations like CKD, HIV, pregnancy, or children with familial hypercholesterolemia, tailored approaches are needed, but statins remain foundational in most cases. For elevated LPA, aggressively control all other risk factors and consider PCSK9 inhibitors in ASCVD patients. And finally, never underestimate lifestyle. Diet, exercise, and weight control are still the backbone of therapy, proven by trials like Predimed, while supplements offer little benefit. And don't hesitate to involve a dietitian, especially in high triglyceride states. So the key takeaway is this accurate measurement, proper risk stratification, and timely intensification of therapy can dramatically reduce cardiovascular events. And if this video helped you understand these guidelines better, make sure to like, subscribe, and share it with your colleagues so we can spread evidence-based practice and improve patient care together.